Dear colleagues, it's a great pleasure to introduce Johannes Hegner. He is a second-year resident in our clinic. He performed medical school at the King's College in London and then started his residency at the NHS in Hastings before he joined our team about half a year ago. His interest is in abdominal surgery, and therefore he will be talking about an interesting topic about surgical emergencies in patients with inflammatory bowel disease. Thank you very much. Enjoy. Thank you.
Thank you for the kind introduction. So welcome to today's talk on surgical emergencies in inflammatory bowel disease. Just to give a quick overview of what I'll be covering today, I'll do a quick recap of IBD. Then I'll talk about Crohn's and ulcerative colitis in turn. I'm talking about the pathology, the surgical indication and techniques, and then going through a case-based example for each. And I'll be ending on a summary slide. Now, inflammatory bowel disease consists of Crohn's and ulcerative colitis. And generally speaking, Crohn's disease will affect any part of the GI tract from mouth to anus, whereas ulcerative colitis is limited to the large bowel. So starting with Crohn's, it is an inflammatory condition, initially presenting in patients aged 15 to 30 years of age. The disease will involve the full thickness of the bowel wall. Typical symptoms will include right-sided abdominal pain, diarrhea, and weight loss. The gold standard to diagnose Crohn's is through endoscopic visualization, where we will see focal ulceration, nodular mucosal changes, that will result in a cobblestone-like appearance in the mucosa. Now, because Crohn's can affect any part from the mouth to the anus, there are different types of distribution. To kind of classify and sort these patients according to the distribution of the Crohn's, we can use the Montreal classification system. And using this system, one can see that almost half of Crohn's patients will have a disease limited to the distal ileum. Roughly a third of patients will have disease of the large colon, and a fifth of patients will have disease of the large colon and of the distal ileum. Only a very small minority of patients will have disease of the esophagus and of the stomach. Not included in this classification, but of equal importance, is that roughly 1/3 of patients with Crohn's disease have perianal disease. Now, this is a very large topic and will require a presentation of its own. So I'll just be focusing on the abdominal surgeries in Crohn's, and I won't be focusing on the perianal disease. Now, surgery in Crohn's should be limited to a specific problem because Crohn's is a relapsing and recurrent condition involving the entire length of the GI tract. Patients that have the disease have it for life, so it's important to leave as much functional bowel behind as possible. You cannot cure Crohn's with surgery, and patients with Crohn's have a very high risk of having surgery. The lifetime risk is around 80%, and the 10-year risk for having abdominal surgery is around 50%, and a third of these patients are going to go on to have another operation within the next 10 years. To cover some of the emergency indications for surgery in Crohn's would be something like perforation, abscess formation, and small bowel strictures leading to obstruction. I'm going to cover each of these in turn. To start out with, we have perforation in Crohn's disease. Here, the indication for surgery is pretty straightforward. In the context of Crohn's disease, a free perforation is likely to stem from the fact that there's transmural inflammation and transmural ulceration that will create this perforation. Now, due to the need to conserve bowel, a limited resection is advised, and this should be guided by macroscopic appearance and not by any histological evidence of inflammation. A diverting stoma can be evaluated if there is, intra-abdominal sepsis or any edematous bowel or any other risk factors for poor wound healing. Now, following on from perforation, we have an intra-abdominal abscess. Now, the pathogenesis for perforation and an intra-abdominal abscess is quite similar. Both will involve the transmural inflammation and ulceration. Having an intra-abdominal abscess is actually quite common. Roughly 10 to 30% of patients with Crohn's disease will develop this in their lifetime. The collection itself may lie intraperitoneal, retroperitoneal, and sometimes rarely intramesenteric. And in general, the treatment for such a collection, a general framework, if you will, is to try to drain the abscess, then try to optimize the patient medically, and lastly, to resect the affected bowel segment. It is important to drain the abscess. You can do this through interventional radiology if the abscess is large enough, and usually we would say larger than 3 centimeters. Otherwise, you can just consider intravenous antibiotics. And studies have shown this procedure to be largely successful in around 70 to 90% of the cases. It is important to consider percutaneous drainage, because if you want to resect the affected bowel segment, you will improve the post-operative rate of complications. So you're going to reduce that. If you have an intra-abdominal abscess, or if the patient is taking any steroids at the time of surgery, you will have an increased risk of having an anastomotic insufficiency. And your risk will be increased by 2.5 times. And if you have both of these risk factors present, it'll be increased by a factor of 6. So after preoperative optimization, one should consider resection of the affected bowel, because this is what has led to the abscess in the first place. Failure to remove this segment can leads to a recurrence rate of roughly 30%. Moving on from the abscess, I just want to cover small bowel obstruction. So in the context of a chronic inflammation, patients will develop fibrostenotic lesions. The most ideal imaging is to visualize it through MRI. This will avoid any radiation and has a high level of accuracy. However, sometimes, or most times actually, in the emergency department, an MRI isn't as available, so a CT scan will suffice. It has similar specificity and sensitivity to an MRI scan, but it just comes with the added radiation dose. Now, depending on the extent and the severity of the stenosis, there are various surgical or medical therapies that we can provide. In a very acute setting where a conservative therapy is not an option, one has to operate and resect the affected bowel. We have a very nice example here. On the left-hand side, you can see dilated loops of small bowel that is due to multiple fibrostenotic lesions downstream in the small bowel, causing an obstruction. And here we can see this chain of lakes effect due to the repeated fibrostenotic lesions. And because there's a kind of a chronic inflammation going on, you will have this creeping fat sign. So this is very pathognomonic for Crohn's disease. In a more semi-elective setting, one can consider endoscopic balloon dilatation. This has a very high success rate and very low rate of complications. However, there's a moderate risk, roughly 50% over 5 years, that patients need a repeat balloon dilatation. So you might need this procedure repeated. It should be noted that this is only for very small strictures, so no longer than 5 centimeters. If there are multiple strictures, if the stricture is longer than 5 centimeters, or if endoscopic balloon dilatation is not an option, or it was done and it didn't work, then one can move to a resection or a strictureplasty. As discussed earlier, resections are somewhat unfavorable as patients are at risk of repeat operations, and they make a short bowel syndrome more likely. Strictureplasty is as effective as a resection in relieving the stenosis, and the rate of recurrence with a strictureplasty is actually comparable to that of patients undergoing a resection. There are different operative techniques. The very conventional one is the Heinke-Mikulich strictureplasty, which can be done for more short stenoses. And for more extensive strictures, one can consider a side-to-side ipsilateral strictureplasty. Just moving on to a case example of Crohn's. We have a 51-year-old patient presenting to the emergency department with intermittent bloody diarrhea, weight loss of 17 kilograms over the last year, and a left-sided abdominal pain. And he's known to have Crohn's disease. Here we can see a CT scan with some findings. Can any of the residents tell me what they see?
I see an abscess in the left paracolic gutter, I guess.
Yes, exactly right. So we can see an abscess right around there. And what would you do? What would your management steps be?
Well, as you said before, we would go for percutaneous drainage first and then maybe optimize the patient later and go for a resection maybe.
Yes, exactly right. We did consider interventional we did consult interventional radiology for drainage here, but because, as you can see, this was a multiloculated complex abscess, this wasn't possible. So with a deteriorating patient and unresponsive to antibiotics, we took them to theater. And here we can see what I described earlier. We can see a fistula in the descending colon, which has created a retroperitoneal abscess. So in this case, we did a resection of the left colon, and we drained and revised the abscess. Due to the edematous bowel and the significant intraperitoneal sepsis, a protective stoma was placed upstream. So this will cover it for Crohn's. And just moving on to ulcerative colitis. Again, it's an inflammatory condition of the bowel. Although here it is limited to the rectum and to the large colon. It is a disease that presents a bit later than Crohn's disease, roughly 30 years of age. Symptoms will include chronic bloody diarrhea and abdominal pain. And typical endoscopic findings here include a red, inflamed, and friable colonic mucosa. Roughly 50% of patients will have disease limited to the rectum. A third will have the disease of the rectum and of the left side of the colon. And roughly a fifth of patients, 20%, will have the disease of the entire colon, so pancolitis. Some indications for emergency surgery here include colonic perforation, a GI hemorrhage, and very acute, severe UC that is unresponsive to medical treatment. For the first part, I'll just be focusing on the last point. So an acute, severe exacerbation of UC occurs in roughly 20% of patients, and we use the Truelove and Witt's severity index to diagnose this. And although we have several medical therapies available, long-term colectomy rates remain quite high. And following just a single episode of a severe UC is associated with a colectomy rate of 40%. A possible complication of ulcerative colitis, which occurs in 5% of these patients, is toxic megacolon, which is a life-threatening complication and is defined by the gross distension of the transverse colon. Here we can employ the Jallan clinical criteria to make a diagnosis, and it combines clinical, laboratory, and most importantly, radiological findings in the context of a UC flare to confirm this diagnosis. Notably, we want to see a diameter of over 6 centimeters of the transverse colon to establish a toxic megacolon in the setting of severe UC. Now, to quickly cover the medical management, the medical management here is aimed at reducing colonic inflammation. Primary therapy is composed of high-dose intravenous steroids, which can be complemented by either biologics or other immunosuppressants, such as cyclosporins. Additional supportive medical therapy is done, such as bowel rest and broad-spectrum IV antibiotics. In a patient with severe UC, you want to do daily abdominal X-ray films to assess for distension of the transverse colon. And surgical intervention here should be considered if there's worsening colonic dilatation or poor response to medical treatment after roughly 4 to 5 days. Should a patient require surgery with ulcerative colitis, generally we'll go for a subtotal colectomy with an endoileostomy and a Hartmann closure of the distal bowel. It is a safe and effective approach. And it is used in ulcerative colitis as this disease is limited to the colon, and therefore, in theory, it should cure the patient of the disease. At a later stage, a completion protectomy and an ileopouch anal anastomosis can be done. And in this center, at this stage, we would place a protective stoma upstream, which in a third step, we would close and revise. A case example for ulcerative colitis is this 57-year-old female who was recently diagnosed with ulcerative colitis. She presents to the emergency department with diarrhea, some amount of blood in her stool, being tired and fatigued, and having a temperature. Just using this information, we can apply it to the Truelove and Witt's criteria and see that she's suffering from acute severe ulcerative colitis. So we admit her to the hospital, start her on high-dose IV hydrocortisone, give her an infusion of Remicade, do supportive treatments such as an NG tube, parenteral nutrition, and high-dose IV antibiotics. However, she develops a distended abdomen on the 4th day of her admission, and which we can't see here. And if we apply the corresponding criteria, we can see that she's having a complication. She's having a toxic megacolon. We have serial X-ray images over the next couple of days that show that the distension is present and is not receding. So my question again to the residents is, what would you do at this point?
Well, like you just said, we would go for a subtotal colectomy with an endoileostomy and then probably come back for completion of proctocolectomy later.
Yes, exactly right. So this lady received a subtotal colectomy and an endoileostomy and had a successful recovery and could be discharged. So I just want to summarize the key points. For Crohn's disease, our aim is to preserve bowel as much as possible, for which we have some specific techniques such as stricturoplasty and limited bowel resections. And then for ulcerative colitis, generally we try to manage them medically as much as possible. But if this disease is having a very severe course, then we will opt for subtotal colectomy. Thank you very much for attending today's presentation. We'll take any questions now.
Johannes, thank you very much for this very nice overview. You nicely summarized the most common emergencies in patients with IBD. And as you mentioned, a majority of the cases can be indeed managed conservatively. However, a majority will eventually need surgery. And as you mentioned, in Crohn's disease, usually a limited resection is the favorable treatment. On the other hand, in ulcerative colitis, total colectomy is usually the treatment of choice. So are there any questions from the audience?
Thank you much for a nice presentation. So you mean subtotal colectomy, not total colectomy?
Sorry, we perform usually a total colectomy. It, however, is okay and fair enough to perform a subtotal colectomy.
Where is the lower boundary of resection if you go for subtotal colectomy? In sigma or?
Yes, exactly. We usually perform a total colectomy, including the sigmoid colon. However, there are other clinics that perform a subtotal colectomy, leaving a small segment of the sigmoid. Correct.
There has been a trend, especially in the United States, where subtotal colectomy with a long sigmoid stump has been performed, where the sigmoid stump is sutured into the fascia, such that if the stump becomes or develops a leak, the leak will go into the subcutaneous tissue and can be drained to the outside. So that was an American technique that was performed for many years. However, today we typically use a total abdominal colectomy and we leave a short rectal stump inside the pelvis. And that has led to some pelvic inflammatory conditions in the past. We've had 2 over the past 8 years, but we continue to do so as this is the European norm, so to speak. How can you keep a patient with such an image on a conservative diet? And I'd like to ask the question to our gastroenterologist.
Yeah, we don't have any prospective trials what to do, and I completely agree. We have to save lives and not to save colons. So that's why I heard that from a gastroenterologist and not from a surgeon. I think 6 years ago, and was a little bit younger. He in every second slide he showed that we have to save lives and not colons, and I think this can be very dangerous. And it's not only the X-rays we should look at. I think it's more important to look at the patient, and that's the important thing. A toxic megacolon, it's not only the diameter, it's also how the patient is, and if he has fever or if the inflammatory signs elevates, I think you have to operate earlier than later.
So if you quickly show Jalan's criteria again for a toxic megacolon, they're very simple. There you go. Very simple. Transverse colon greater than 6 centimeters, and 3 of the following criteria: elevated temperature, heart rate above 120, and a white count, plus at least one of the following: dehydration, altered mental state, electrolyte disturbance, hypotension. And I can tell you what, in all of these patients will fulfill these criteria except some very few. So Andreas, when should we operate, or is it safe to leave such a patient with the gastroenterologist?
It's a tricky case. I think the clinical situation is very important, and I think we should not wait too long. Rather take out the colon in such a situation rather than risking a perforation.
So we've had a similar patient just a few weeks ago, and there were quite a few discussions, and we actually put a note into the chart of the patient, said, hey, the indication in our opinion is there. This patient should be taken to the operating room, and at the hands of our GI specialists within 2 or 3 days, the toxic megacolon was resolved. They used all kinds of different medications up to IV cyclosporin, so this sometimes can be of value and it can work. However, I think as a general rule, this is an indication for a total colectomy, period.
Thank you very much. So if someone has had a toxic megacolon, how big is even if it resolves, how big is the risk of recurrence?
I don't know how big the recurrence is. I don't think that there are any data, but I can tell you these patient Professor Turina just mentioned, I saw her last week and she's fine. She definitely doesn't have a toxic megacolon, but she's still highly inflamed. And I'm not sure if we can save the colon with our medication. So maybe at the moment, yes, but I think that the risk that this patient needs an operational colectomy in the future is very, very high.
I also, concerning this, I would just like to highlight that most conditions can be managed conservatively. However, a majority will require surgery, and the time in between, we should optimize the patient. So that's the surgical outcome might be better once we have him in the theater. So all the measures Turina just mentioned in preoperative optimization is absolutely crucial for a good outcome. Thank you very much, Johannes, for this nice overview.